So all set. So we are about to start the ECG sessions. Remember that this ECG cannot be taught just like that in one class. That too when we are in a remote location on an online platform. Nonetheless, we will try to make it as interesting as possible. This is a dry subject for many, but not for us, because we will make it very interesting. And this can go on up to around 6 or 8 classes, depending on at what speed we are going to cover all the aspects of training that is required in ECG. So a clinical approach to ECG. This has been conducted as a workshop in GEMS itself. So I'm going to use the same slides for you also here. So there at the time I was available physically there, but now doesn't matter. We are from a remote location we are doing. So the contents of today's presentation or the presentation of ECG itself as a whole will be to learn something about the paper, the time intervals and the amplitude, the normal intervals that are there and the voltages of each of the normal waves and the different ECG waves, rate determination, a very simple approach, and then leads, particularly limb leads and chest leads, 12-lead camera concept, the QRS axis, normal right and left axis, left ventricular, right ventricular hypertrophies and left atrial and right atrial enlargement, bundle branch blocks, LBB and RBB and trifascicular block and other things. Important cardiac arrhythmias we will learn. This itself will be a very interesting topic because none will be covering you how to diagnose arrhythmias correctly in the ECG. Then comes the ischemic heart disease with angina, fringe metal angina, microvascular angina, chronic stable angina, and then acute coronary syndromes, including myocardial infarction, unstable angina, clinical implications, NSTEMI, STEMI, QA infarction and treatment options, time sequence of ECG changes, serial ECGs, acute MI, old MI, which wall is having infarction, the location of MI, and which vessel is affected. All that can be diagnosed in the ECG itself. And miscellaneous conditions, non-specific changes of ECG, what are the pitfalls and cautions we have to take. Like that, it runs into 12 sections. Assuming we cover 2 or 3 sections each time, it might take around 6 to 8 classes. Particularly cardiac arrhythmias and infarction are very huge sections. They will take more time. So let's continue. The flow should start for all of you. Certain important precautions have to be taken before even interpreting the ECG while recording the ECG itself. Correct lead placement and good contact of the lead with the chest wall is essential. If the lead is not making contact, naturally the waveform will be disturbed. You'll get a very artifact and an irregular, disturbed waveform. Proper earthing correction of the ECG equipment should be avoided and avoid other gadgets connecting to the same ECG plug. If there is a ECG plugged to one outlet, no other gadget like refrigerator or air conditioner or any other thing or motor should be connected to the same outlet, same board. And always do not forget to record ECG in deep inspiration. Particularly look for L3 and AVF deep inspiration must be done. This is not routinely done in your hospital practice and your ECG technician doesn't do it, but you have to ask for 12-lead ECG with deep inspiration, L3 AVF also you have to write. And you should know how to compare serial ECGs if they're available. Relate the changes to the age of the patient, the gender of the patient, and the clinical history. Because no investigation by itself is simply adequate to diagnose anything unless you have the background of the patient, the clinical history, what is the age of the patient, and what is the gender of the patient. Consider comorbidities that which may affect the ECG. Make a photocopy of the record because most of the records are thermal records. They will fade away in a matter of 3 months or 6 months. So always better to make a photocopy of the ECG for future reference. For those of machines which are not having thermal recording but as a printing, just like laser printing, it's okay. That we do not require to take any photocopies. Interpret systematically to avoid errors. Don't jump to conclusion. Yeah, this has got atrial fibrillation. This is having infarction. Like that, don't jump to conclusion. Go step by step so that you will not miss anything and avoid errors. These are some of the important precautions that I would like to keep in your mind. Another thing is verbatim, you don't have to write whatever is there on the slide because I'm going to share the slides with you. But up to the point what we have discussed today, those slides will be available as a PDF to you. So try to understand more rather than writing something which is there on the slide. That will consume your time and your attention on whatever I am speaking will become less. That is why I urge you not to start writing any important points. You can make note, but not verbatim try to copy the slide because the slide will be available. And anyway, you can't write the tracings and ECGs there. Those ECGs you have to see physically only. So the slides will be shared with you in the PDF form, which you can always use for your future reference. Now, with this background, we will start. So this is the wave tracing of the single ECG record. That is, one cardiac cycle is recorded, it will have these many waves, and all of these waves you should be familiar. So let us say I start with the first one. Number one wave is called the P wave. Number two wave is called the Q wave. Then comes the QRS. Then comes the junction point and the ST segment. This is the ST segment. And then the T wave and the U wave. So what are we having? P, Q, R, S, T, P, Q, R, S, T and U. These are the waves that are there in the ECG. And there are also what are called the intervals. Intervals and waves are different. A wave is starting from this to this is the P wave. That is the wave. When we say interval, it also includes a segment. A segment means a part of the ECG which does not have any electrical activity is called a segment. And that segment plus the wave will be the interval. So P wave is starting from the beginning of the P wave and ending of the P wave is the P wave. PR interval is starting from the P wave to the beginning of the Q wave is called the PR interval, or that is number 2. And then QRS complex is starting from the Q wave to the end of the R wave is the QRS complex. And again, it is a wave. It doesn't have an interval. QRS is 3 waves are there. So naturally, we will call it as QRS interval. It is not one wave. When more than one wave is combined, you can say interval. Only one wave is there, you call it as wave. One wave plus sort of isolated segment that is associated with that isoelectric segment, it is called interval. QRS also is also called interval, QRS interval. And you have got ST segment starting from the S wave to the beginning of the T wave. Because this is the S wave end of S wave to the beginning of the T wave is called the ST segment. This is called the fate line of the ECG because ST elevation and depression signify infarction and ischemia respectively. There is a point called J point, which is a junction point of QRS complex or the S wave with the ST segment. S wave joining the ST segment is called the J point because this J point depression is commonly seen in ECGs and interpreted as ischemia, which is not. So you must know whether it is simple J point depression or ST depression. For that reason, you should know what is the J point. Then comes the T wave. And finally, you have a wave which is not normally recorded or even given note of is U wave. So these are the various things. We have the PR interval, we have the QRS interval between the Q wave and the S wave, and we have the QT interval from the starting of the Q wave to the ending of the T wave is called the QT interval. PR interval, QRS interval, QT interval. What are the segments? PR segment, ST segment, and TP segment. That is, end of this first cycle to the next cycle is called the TP segment or UP segment. If U is there, UP segment. If U is not there, it is called TP segment. So what are the things we learned on this slide? P wave, QRS complex, J point, ST and ST segment, and then the T wave and the U wave. What are the intervals? PR interval, QRS interval, and QT interval. So what is the significance of these things? We will see in the next slide. What is P wave? P wave is due to the contraction of the atria. The electrical representation of atrial contraction is called the P wave. And it has got a duration of 0.12 seconds. You should always remember the normal durations. Whenever the duration is prolonged, it is disease. So P wave normally is 0.12 seconds. It is due to the electrical contraction of the atria. The electricity passing through the atria will inscribe a wave which is called the P wave. PR interval is beginning of the P wave to the beginning of the QRS complex is the PR interval, and that is normally is 0.2 seconds. Very important part of the ECG. Prolongation of the PR interval is disease. Anything more than 0.2 seconds is prolonged, this one. And QRS complex is a ventricular. QRS complex is 0.08 seconds. QRS complex is 0.08 seconds. That is, we will come to the number of squares a little later. Remember, for now, QRS complex is 0.08 seconds. ST segment is the electrical silence. It is isoelectric, neither shifted upward nor shifted downward. T wave is a repolarization wave. What is QRS complex? Ventricular contraction. Electrical contraction of the ventricle is recorded as the QRS complex. Electrical contraction of the atria is recorded as the P wave. And the segment between P wave and QRS is called the PR interval or PR segment. And that segment is again, it is the delay at the AV node for the conduction of the atrial impulse into the ventricle. That is important because AV nodal delays can mean heart blocks and other diseases of the heart. ST segment is isoelectric and electrical silence and is the baseline. And if it shifts up and down, it shows infarction or ischemia. What is T wave? Repolarization of the ventricles. Its duration is 0.12 seconds. What happened to the repolarization of the P waves? It is embedded in the QRS complex. That's why we don't see the repolarization of the atria. But the repolarization of the ventricles is seen separately, which is called the T wave. The QRS interval is duration of the ventricular contraction that equal to duration of the QRS complex, and that will be 0.08 seconds. And QT interval is from Q to T. Beginning of the Q to the end of the T is called the QT interval. This is very important because prolongation of the QT interval is seen with many of the drugs, and it could be a very potentially dangerous condition, QT interval prolongation. So you should always have an eye on the QT interval. There is what is called the TP segment, or the electrical silence also is there. So that is 0.2 seconds will be the T to the next P wave is the electrical silence. Okay. Now, I will show you the paper for a while and then come back to the ECG proper once again. Let me do that in a second. There will be a gap of a few seconds, a few minutes, because this particular presentation does not have those slides on the paper, but you should be familiar with the paper also. I am going to show you the paper also now with this one. I am familiarizing you with the ECG paper. ECG paper is important to know. It is like any other graph paper, but the intervals, what is on the x-axis, what is on the y-axis, you must know, and what is the distance between one small square and what is the distance between the one large square also, you must know. ECG paper, if you have, anyone of you have ECG with your ECG paper, you can see the ECG paper. All of you put off your videos also. We don't require your videos. Okay. Now, you see on the x-axis, the time is recorded in seconds. Time is recorded in seconds on the x-axis. This is the x-axis. And this is the y-axis. Y-axis, the amplitude is recorded in the y-axis. You can see in the ECG paper, there are some bold lines like this. This is a bold line. So there is another bold line like that. Between one bold line and the next bold line, the duration is 0.2 seconds. How much? 0.2 seconds. Cardiac cycle is 0.8 seconds. That means the ECG will be over. The one cardiac cycle will be over in 4 bold squares, 4 big squares. We call them as large squares or big squares. So the distance between one bold line and another bold line is exactly 0.2 seconds. And this is called one large square or one big square. You can see this is the big square. This big square. This big square is divided into 1, 2, 3, 4, 5 small squares. So each of the small squares will be 0.2 divided by 5, which is equivalent to 0.04 seconds. Now, on the x-axis, what is the time? One large square or the big square between two bold lines. One big square on between the two bold lines is 0.2 seconds. One small square is equal to 0.04 seconds. Because we want to measure very precisely, we should know the normal size of each of these waves on the x-axis. Then on the y-axis is recorded the amplitude in millivolts. What you are seeing is 250 volts current, 250 volts or 220 volts in your house. Here it is millivolts. That is 1000 part of an volt is a millivolt. So that is the smallness of the current that passes there in the ECG. So if you take the two big squares like this, two big squares, so that is one big square is this one and another big square is below. So both of them together is two big squares is equal to 1 millivolt. Two big squares is equal to 1 millivolt on the y-axis. So how many small squares are there? 1, 2, 3, 4, 5, 6, 7, 8, 9 and 10. 10 small squares are there in those two big squares. So each of the small square will be 0.1 millivolts because 10 small squares is 1 millivolt. So one small square will be 1/10 of that, which is 0.1 millivolt. What this boils down? ECG is a graph paper. It has got an x-axis and a y-axis. The x-axis is representing the time in seconds. The time duration is in one big square, the time duration is 0.2 seconds. One small square is equal to 0.04 seconds. Okay. Vertically, in the y-axis, it is the amplitude. Two large squares is equal to 1 millivolt. So one small square will be equivalent to 1/10 of 1 millivolt, which is equal to 0.1. This is what you have to understand. Okay. The bold lines are important for us to go ahead because they only tell you quickly to look at the ECG, how many bold lines a wave occupied or how many small squares a wave occupied. You will be able to see that. It is like any other graph paper. X-axis represents the time duration, y-axis represents the voltage or amplitude, and then voltage or amplitude. X-axis 1 millimeter is equal to 0.01 and 10 and 5 millimeters or one big square is equal to 0.2. So y-axis 1 millimeter is equal to 0.1 millivolt and y-axis 2 big squares is equal to 1 millivolt. This is what we have understood about the paper. Now you see here, the time intervals also are important. Again, in a different way, we are representing here. So this is 5 millimeters or this is equivalent to 0.2 seconds. 5 millimeters is equal to 0.2 seconds. 1, 2, 3, 4, 5 such big squares is equal to 5 into 0.2, which is equivalent to 1 second. So this total will be 5 squares will be 1 second because each big square is equal to 0.2 seconds. Each small square is equal to 0.04 seconds. This also we understood. Each small square is equal to 0.04 seconds. 5 big boxes, 1, 2, 3, 4, 5 big boxes is equal to 1 second, which means in a minute, there are 60 seconds. 60, 1 second is equal to 5 big boxes. That means 300 big boxes or 300 big squares will be there in 1 minute recording. If you record the ECG for 1 minute, you will see 300 big boxes would have gone through there. Or that is because 1 second is equal to 5 big boxes, or 1 big box is equal to 1/5 of 1 second, which is equal to 0.2 seconds. Okay. Time is represented on the x-axis. Cardiac events occur very precisely in very small time frames of milliseconds. They won't be occurring for 2 minutes or 3 minutes because the entire cardiac cycle should be over in less than a minute, less than a second. 0.8 seconds is the cardiac cycle. So waves will be even small fractions. So each small square is 0.404 seconds. 1 millimeter in size on the paper, but the duration wise, it is 0.04. Each big square on the ECG represents 5 small squares, which is equal to 0.04 into 5 is equal to 0.2 seconds. 5 such big squares will make up 1 second. That means there are 25 millimeters of paper. 1 second is 25 millimeters of paper or 5 big squares. 1 minute is equal to 5 times into 60 seconds, which is equal to 300 big squares. So this is all about the paper. Now we go into the intervals. And then, so you see here, the first wave is called, you should know, I have to identify the waves. The P wave, and then the QRS complex, then the T wave, the U wave, the TP segment. This is called the RR interval, which we have not seen in the previous slide. RR means the distance between one R wave and the subsequent R wave is called the RR interval. This is the QT interval. QT interval is from the beginning of the Q wave to the end of the T wave, which is called the QT interval. The rule of thumb is QT interval is roughly half of the RR interval. So if the RR interval is 1 cardiac cycle is 0.8 seconds, QT interval will be half of that or 0.4 seconds. Remember, QT interval is half of the RR interval. That's what you have to understand. QT interval is half of the RR interval. Normal RR interval is how much? 1 cardiac cycle. 1 cardiac cycle is 1 R wave to another R wave, 1 contraction to another contraction. That is the RR interval. That is equivalent to usually 0.8 seconds. Okay. Half of that will be 0.4 seconds. That is the QT interval. So what are the waves we have understood? P wave, atrial contraction, PR segment, AV nodal delay, QRS complex, ventricular contraction, ST segment, isoelectric part where the ventricle is relaxing, T wave is repolarization, QT interval is from the beginning of the Q wave to the end of the T wave, which is half of the RR interval. RR interval is the distance between one R wave and another R wave, which is nothing but the cardiac cycle, which is normally 0.8 seconds. Yeah, this I have already explained to you. P wave is atrial contraction. Normal duration of the P wave is how much? 3 small squares, which is 0.12 seconds. PR interval is from the beginning of the P wave to the beginning of the QRS. Okay, and PR interval will be 0.2 seconds. P wave is 0.12 or 3 small squares, whereas PR interval is 0.2 seconds or 5 small squares or 1 big square. QRS is ventricular contraction. Normally it is 2 small squares. Each small square is 0.04. 2 such small squares will be 0.08. ST segment is isoelectric. QT interval is from the beginning of the QRS to the end of the T wave. Normally it is half of the RR interval. Normal QT interval is 0.4 seconds. RR interval is 1 cardiac cycle from one R wave to another R wave, and it is usually 0.8 seconds. Half of that is QT interval. So this slide I have already explained to you in the other presentation. Now you translate them into intervals. P wave is atrial contraction. How many small squares? 3 small squares. PR interval is P beginning to QRS beginning. It is 5 small squares. QRS complex ventricular contraction 0.08. 2 small squares. And then ST segment is isoelectric. There is no question of so many squares or anything. T wave is repolarization. Usually it will be 3 small squares, which is 0.12. QRS interval is 0.08, which is the QRS complex itself. And QT interval from Q to the end of T is 0.04 seconds, which is 0.04 seconds. 0.2 is 5 small squares. 0.4, 0.4 is equal to 10 small squares. TP segment, isoelectric, and electrical silence is again 5 small squares. So this is how you have to remember the various this one. So I ask you, what is the duration of PR interval? You should say 0.2. What is the duration of QRS complex? 0.08. What is the duration of P wave? 0.12. What is the duration of QT interval? 0.4. What is the duration of cardiac cycle? 0.8. Like that, you should be able to remember those things. Now, one of you open the mic and identify the wave I am showing. What is this wave? Can you open? You will not be able to open. Only Rashma will be able to open. That is the P wave. The second one is the PR segment. Third one is the Q wave. Fourth one is the QRS complex. Fifth is the S wave. Sixth is the ST segment. 7 is the T wave. 8 is the TP segment. Duration of this is 0.2. Duration of one small square 0.04. Amplitude wise, this is 0.1 millivolt. And how many millivolts this QRS complex? 1, 2, 3, 4, 5, 6, 7, 8, 9, 11. 11 into 0.1 millivolts is that is 11 boxes up is the QRS. What is the height of the P wave here? 1, 2. That is only 0.2 millivolts. What is the height of the T wave? 1, 2, and 3. That is 0.3 millivolts. What is the duration of PR interval here? From here to here. That is 1, 2, 3, 4. That is 0.16. Up to 0.2 is normal. 4 small squares is equal to 0.16. Like that, you have to understand whatever are the intervals and the amplitudes, you should be able to translate them. Okay. Now, how do you connect the ECG to the various electrodes? So the man is connected to the various electrodes, and there is a lead selector here in this one, which selects lead 1, lead 2, lead 3, AVR, AVL, AVF for the chest lead. And there is a recorder here. This is recorded on the computer and displayed on the screen, which can be saved on the hard disk or on the computer itself. Today we have computerized ECGs. The person is connected to the machine, and machine has got a lead selector and an amplifier system. And this amplifier amplifies the waves and shows on the screen. And this amplified is displayed on the screen, can be captured as a record and stored or printed on a paper. So what are the standard 12 lead, limb lead, chest leads? What are standard leads? So you have to understand now what are these leads and which lead you need to look for what changes also. So there are 6 limb leads and 6 chest leads. How many are there? 6 limb leads and 6 chest leads. Total 12 lead ECG. Standard ECG is a 12 lead ECG. 6 limb leads and 6 chest leads. What is lead 1? Lead 1, the positive terminal is connected. Any lead will have a positive terminal and a negative terminal. To capture the potential difference, always you must have a positive terminal and a negative terminal. Even in a battery, you see the battery is like this. This is the positive terminal and this is the negative terminal. Negative and positive. So the difference between them is the electrical current that flows through, measured in terms of millivolts or volts, whatever it is. 2 volt battery, 4 volt battery, 5 volt battery, like that we will see. So there is a terminal, positive terminal, there is a negative terminal for any electrical gadget. So here also, for us to get the electrical recording, we use a positive terminal and a negative terminal. The positive terminal is the left arm and the negative terminal is the right arm. Okay, as far as ECG is concerned, only 1 foot, left foot. Right foot is neutral. We don't consider the right foot. ECG man has got only 1 foot, 2 arms and 1 foot. The right foot is connected to the neutral so that there will not be any shock and there will not be any other disturbances or anything. The right foot is used as a grounding electrode or the neutral electrode, and the left foot is only used. So then the first lead is left arm positive, right arm negative. Lead 2 is right arm negative and foot positive. Foot we will say, we don't have to say left foot because there's only 1 foot we use. Foot is positive. Whenever foot is used, it is always positive. Whenever left arm is used, it is always positive. We try to keep the right arm negative usually. So in the lead 1, left arm is positive, right arm is negative. Lead 2, foot is positive, right arm is negative. In lead 3, foot is positive, left arm is negative. Okay, the current flows towards the positive electrode. From the negative to the positive, the current will be flowing. So the direction of flow in the first lead will be towards the left arm. In the second lead, it will be towards the foot. In the third lead also, it will be towards the foot. Direction of the current flow is from the negative to the positive. This placement you have to understand. So this is what exactly is illustrated by the, so that is the right arm, left arm positive, right arm negative is the first lead, foot positive and right arm negative is the second lead, and the foot positive and the left arm negative is the third lead. This is lead 1, lead 2 and lead 3. These are Netter's drawings. Netter's drawings are internationally famous medical drawings. We will be using several of his medical drawings here, and we remain very thankful for the Netter's drawings throughout. Okay, now some more people are coming even now. Let us admit them. The lady I told she has to admit, she is not doing anything. Anyway, I have admitted them. Okay, so now you understood what is lead 1, what is lead 2 and lead 3. Coming late is of no use. You have to come on time. Standard ECG is recorded in the 12 leads. There are 6 limb leads, L1, L2, L3, AVR, AVL, AVF. There are 6 chest leads, V1, V2, V3, V4, V5 and V6. L1, L2, L3 are called the bipolar leads because we are using 2 poles, a positive pole and a negative pole. These are called the bipolar leads. L1 is between the left arm and the right arm. L2 is between the left foot and the right arm. And the L3 is between left foot and the left arm. Always the first one is positive. This is positive, this is negative. Likewise, here foot is positive, right arm is negative. Here left foot is positive and left arm is negative. This part we have seen in the diagram in the previous one. Now we have to identify the 3 other leads. What are the 3 other leads? Lead AVR, AVL and AVF. Here, these are called the unipolar leads. Uni means single pole. Unipolar leads. You may ask me how there will be unipolar lead without a second minus lead. So what they will do is here, the positive one is taken and rest of the body is connected to the negative terminal. So that the potential difference between the rest of the body and the lead that is being recorded is called the positive lead there. This is a positive lead here in the AVR is the right arm. The name itself suggests AVR. R is the right arm. R is the right arm here, positive, rest of the body is negative. What is the small a? Small a is augmented unipolar leads. V is lead, R is right arm is the lead, positive lead, VR is right arm positive, A is augmented. The potential differences will be very small. So the machine augments them or increases them or increases the magnitude of them. That is why they are called augmented unipolar leads. Lead AVR is an augmented unipolar lead where R is the recording lead, rest of the body is negative. AVL is left arm is the recording lead, remaining part of the body is negative. Augmented unipolar lead left. First one is augmented unipolar lead right, augmented unipolar lead left, augmented unipolar lead foot. We only have one foot. ECG man does not have the right foot. Right foot is always the connected to the neutral. So you have to understand augmented unipolar. There are 3 limb leads and 3 augmented leads. Limb leads are L1, L2, L3. Bipolar leads, unipolar leads are AVR, AVL, AVF. 6 together are called the limb leads because their potential difference is tapped from the limbs. There are 6 limb leads, 3 bipolar and 3 unipolar. So standard ECG is recorded in 12 leads, 6 limb leads as I told you, L1, L2, L3, AVR, AVL. AVF, 6 chest leads are placed V1 to V6. AVR, AVL, AVF are called the unipolar leads. AVR is from the right arm positive, AVL left arm positive, AVF is equal to left foot positive. Where is the negative terminal? The rest of the body is connected to the negative terminal. That is how the design is done. Now we need to know where to place the chest leads. The nurses will be placing wherever they want without any proper order. That way, ECG of the same person recorded today will not be comparable to the ECG recorded tomorrow once the position of the lead varies. So you have to properly place the chest leads at the right place. Then only it is comparable between patients and between the ECGs of a same patient recorded in 2 different time points. And whatever you are saying V6, internationally people should understand what is V6. Internationally, whatever you say V1, they must understand what is V1. So that is why it is standardized to keep the leads exactly the correct position on the chest. So chest should be preferably exposed and then properly sort of the jelly should be applied to the lead and a contact should be made. This is fourth one is the mid-clavicular line, the MCL, and this is the anterior, and this is the mid-axillary line. This is the anterior, this is the axillary fold, anterior axillary line. This is the mid-axillary line. This is the mid-clavicular line. So mid-clavicular line, anterior axillary line, mid-axillary line are 4, 5, and 6. Okay, in which space? 5th space. And here this is the 4th rib, V1. And then same position on the left side is V2. And V4 is in the 5th space in the mid-clavicular line. And V5 is in the anterior axillary line. V6 is in the mid-axillary line. And V3 is exactly between V2 and V4. So this is the lead placement. I will show you in the next slide in a describing way. So that is the V1, that is V2. V is lead. V stands for lead. V is the voltage potential difference you are measuring. That is why it is symbolized as V. V1 means first lead. V2 is second lead. V3 is third lead. V4, V5, and V6. Where is V1? V1 is in the 4th intercostal space on the right side of the sternum. 4th right sternal border, 4th intercostal space at the right sternal border. V2 is the same space, same right, but in the left side of the sternum. 4th intercostal space, left sternal border. 4th intercostal space, left sternal border. V5 is in the 5th intercostal space in the mid-axillary line. This is the V5. V3 is in between V2 and V4. So V3 is equidistant between V2 and V4. V5 is in the fifth intercostal space, anterior axillary line. V6 is in the fifth intercostal space, left mid axillary line. We have to say left because we are keeping the leads on the left side. Only if the patient is having dextrocardia, then we will interpose the leads onto the right side, and V1 will come here, V2 will go there, V3, 4, 5 will go to the right side. Then you have to say V1R, V2R, V3R, V4R, V5R, like that. To say that, you have recorded on the right side. If you say simply V1, it is a normal recording. If you say V1R, your placement of leads for the dextrocardia. V5R is equal to fifth intercostal space, anterior axillary line on the right side. So without mentioning that R, normally standard recording is here. So what is, again I am repeating, V1 is the right sternal border, fourth intercostal space. V2 is the left sternal border, fourth intercostal space. V4 is the fifth intercostal space, mid-clavicular line. V3 is equidistant between 2 and 3, 2 and 4. V5 is the fifth intercostal space, left anterior axillary, left fifth intercostal space, anterior axillary line. And then mid-axillary line, V6 on the left side. These are the lead placements. Now, what did you understand? You understand the lead placement of L1, L2, L3 and AVR, AVL, AVF, and also the chest leads. Now, we will do the rate determination for today, and probably if time permits, we go further. How do you determine the rate of the heart rate using a very simple approach? Okay. Now, I told you there are bold lines and the normal lines. The bold, this is one bold line, this is another bold line, this is another bold line, like that. There are bold lines on the ECG. So the distance between the bold lines, we know this distance is 0.2. This distance is 0.4. This distance is 0.6. And this distance is 0.8. Because we are adding point like that, it goes on. Now, the first bold line, we start. From there, where is the second bold line? That we label it as 300 line. The third bold line is labeled as 150. The next one is 100. Next one is 75. Next one is 60. Next one is 50. Next one is 43. Next one is 47. You have to memorize 300, 150, 100, 75, 60, 50, 43, 37. Why should I memorize? Very easy to identify the rate. Supposing one QRS complex has fallen here, another QRS complex has fallen here, then it has occurred within 0.2 seconds. That means the rate is 300. If the other way around, the second QRS complex did not fall there, but has fallen there, then the rate is 150. Instead, the QRS complex occurred on the third bold line, rate is 100. Okay. The fourth one is, if it comes on the fourth line, the rate is 75. If it comes on the fifth line, the rate is 60. And if it comes on the sixth line, the rate is 50. If it comes here, the rate is 43. If it comes here, the rate is 37. So identify the one QRS complex which is on the first bold line and see when is the second QRS complex next to that occurring. If it is occurring on the first bold line, 300. If it is occurring on the second bold line, it is 150. It's 150 line. 100, 75, 60, 50, 43. You may ask me, suppose it doesn't fall on the second bold line, but wherein, suppose it has fallen somewhere here instead of that. That means it's less than 300, but close to 300. Suppose it has fallen here. It is more than 100, but slightly closer to the 100. Suppose it has fallen exactly this, the next ECG complex has fallen. Here it is between 75 and 60. Roughly you can say, what is your interest? Not to know the heart rate exactly. Is it tachycardia? Is it bradycardia? Is it normal heart rate? What is normal heart rate? Anything between 60 and 100, this is normal heart rate. Anything more than that is tachycardia. Anything less than that is bradycardia. Clinically suffice if you know if the patient has got normal heart rate or increased heart rate or bradycardia. So how do I know? I have labeled the lines now: 300, 150, 100, 75, 60, 50, 43, and 37. Using this, I am going to show you an ECG. You will identify the rate. So how this numbering has come, some logic is required, isn't it? I am going to show you that logic also in the next slide. 1, immediately after 1 it has come. That means only one big square to another big square. The duration is 0.2 seconds. So in a minute, there are 60 seconds. So 60 seconds divided by 0.2, the answer is 300. That's why we labeled that line as 300 line. When you go to 2 squares, it becomes 0.2 into 2, that is 0.4. 60 divided by 60 is number of seconds in a minute. So in a minute, the rate is counted per minute. So per minute, 60 divided by 0.4, the rate is 150. There are 3 squares, 60 divided by 0.6, 60 divided by 0.6 is equal to 100. Then next one is the 4 squares are there, 0.8, 60 divided by 0.8 is equal to 75. Likewise, if it is 5 squares, it is 1 second. 60 divided by 1 is equal to 60. That line is labeled as 60. And the 6th one is 1.2. 6 into 0.2 is equal to 1.2. 60 divided by 1.2 is equal to 50. Likewise, divided by 1.4 is 43. This is 37. So we labeled the lines as 300, 150, 100, 75, 60, 50, 43, and 37. Depending on it occurred in the first 1 square, after that, or 2 squares, or 3 squares, or 4 squares, or 5, 6, 7, 8. Now, the white one here is the normal heart rate. Anything above is the tachycardia. Anything below is bradycardia. Clinically, if I suffice for me to know whether the heart rate is between 100 and 60, or it is more than 100 or less than 100. Exact heart rate can also be calculated from the ECG, but this is a very quick way of interpreting the heart rate in the ECG. Normal, tachy, and brady. Now let us see the ECG. Now you identify. I will allow you to open the thing, and one of you, I will call the name. You can open and tell me what is the answer. Okay. Now anybody can open now. So now in this ECG, what is the bold line? This is one bold line. Likewise, this is another bold line. So find out the rate using the above trace. So let us see. Okay. Now I am randomly asking somebody. So let us say Anusha. Can you tell me the rate in the ECG? What is the distance between 2 RR intervals? So this is one square roughly. This is another square and little more. So that is, if it is 2 squares, it is how much? First is 300, second one is 150, 3 squares is 100. So it looks that there are 3 squares here. From here to here is 1 square, here to here is another square, from here to here is another square. That is 3 big squares are there. So when it is 3 big squares, what will be the heart rate? 100. So 100 is the heart rate. So by looking at the ECG itself, straight away you can say, yeah, the RR interval is occupying roughly 3 big squares. That means the rate is 100. So this is easy to say. So this line is the 300. This is, let's say the ECG has occurred here. This line will be 300, 150, 100, 75, 60, 50, 43, and 37 line. This is the numbering you have to keep in your mind. Then automatically you will be able to understand the rate exactly. You can find out the rate very quickly. Now, what is the rate in this ECG? Anybody can open and tell. It has occurred exactly on the bold line. So how many bold lines again? 1, 2, 3, 4, 4.5. So this is 300 line. This is 150 line. This is 100 line. This is 75 line. This is 60 line. So the heart rate is between 75 and 60. Midway between 75 and 60. What is the midpoint between 60 and 75? Maybe 67 or 68. Here we are given an option of 67. So what will be the heart rate? 67 will be the heart rate. So you understand? This is very simple to use this to know the heart rate here. 300, 150, 100, 75, 60, 50, 47, 43 and 37 are the numbers you have to remember. In this case, this complex has occurred on the bold line. The next ECG complex has occurred here. How many squares away? 300 line it is not correct. 150 not correct. 100 also is not there. 75 is not there. Yeah, it is less than 75, but more than 60, midway between them. That is why it is 767 heart rate. Now, look here. What is the heart rate here? To say the heart rate, you must first look at the RR intervals. This is the R to R. This is the R to R. This is the R to R. See here whether all the RR intervals are same or differing. This is shorter, this is longer, this is in between, this is again longer. Like that, the RR intervals are varying. The RR intervals are varying. You will not be able to pinpoint and say this is the heart. Then how do I do that? Then you have to do what is called the L2 long strip. You have to take the long strip for L2 lead and then calculate the number of complexes per 20 seconds or 40 seconds, depending on the strip, and update it for 1 minute. So here the ECG is irregular. Because the rhythm is irregularly irregular, I will not be able to calculate the heart rate. This should be the answer. The answer should be the RR intervals are varying. As you can see here, none of the above, as it is an irregular rhythm. Okay. So this is how you determine the rate. I don't know whether we have time. Maybe QRS axis we will try to finish today and then go for the rest on another day. So you know how to know the rate. Rate determination I have told you. You have to number the lines. First one after the QRS complex occurs, the first square bold line is 300. Next one is 150. Next one is 100, 75, 60, 50, 47, 43 and 37. These are the numbers you remember in your mind. And depending on when the next complex occurs, you decide. Suppose it is between 60 and 75, and you see whether it is nearer to the 60 line or the 75 line, you can guess the heart rate. So this is a very quick method of finding out the heart rate. Anything between 60 and 100 is normal, more than 100 is techie, less than 60 is Brady. Now, we have to look at the QRS axis. What is the QRS electrical axis? This axis here is not the anatomical axis, but the electrical axis of the heart. So, we have now got the 12 leads. But we are not considering all the 12 leads here. For the axis, we only consider the frontal plane leads. The frontal plane leads are 6 limb leads, which are L1, L2, L3, AVR, AVL, AVF. Supposing you put a circle like this on the chest and label the degrees and start with the left, because most of the heart is to the left side. L1 we call it as 0 degrees. This is L1. Positive is here, negative is here. We know L1 left arm is positive and right arm is negative. For the foot, the vertically down, the foot is positive here, and then this is negative on the opposite side. This is the foot, which is the AVF. L2 is left arm, and the left foot or the foot is positive here, and this part is the negative one. L3 is again foot is positive here, and this is negative here. So AVR, R is the positive lead. We know there, augmented unipolar lead. R stands for the right arm. This is the positive, and this is the negative for that lead. So now we start labeling this is called the hexaaxial system. Hexa is 6, axial system. We are using the 6 axes, and this is called the hexaaxial system. If the heart axis is in this direction, then you call it as 0 axis. First one is the hexaaxial system, the first one. So that is second. The first one is towards the L1. The second one is towards the left side, but little above the L1, which is minus 30. That is the AVL. So that is the L1. AVN, AVL, L1, and these are the left leads. So when there is a left axis, you will see the changes in L1 and AVL. So L1 and AVL are called the left cameras. Imagine there are 2 cameras which are positioned on the left side. The one camera is dead horizontal, which is the L1. One camera is minus 30 degrees above the horizontal camera, that is the AVL. As though somebody is picturing here, the electrical potential is tapped as though somebody is taking a picture from that angle. So these are called the left-sided leads. Left-sided leads means L1 and AVL. Then comes the L2. L2 is towards the foot plus 60, and then there is what is called the AVF, that is dead vertical, which is plus 90, and then you have got the L3 lead, which is plus 120. Why these are always we say plus? Because these are the leads which are positive. AVF foot is positive, L2 also foot positive, AVF also is foot positive. In L1, the arrow is towards the left arm, AVL also towards the left arm. So any lead like plus 60, plus 90, plus 120, all this area is vertical or inferior. Inferior leads. These are called the inferior leads. Among the 6 leads, you must now understand what are the inferior leads, what are the left leads. So left leads are AVL and L1. Inferior leads are L2, AVF, and L3. And we are now left with only one, which is pointing towards the right side, which is the right-sided lead. That is the AVR. When we say AVR, augmented, V is lead, unipolar lead, R is the right arm positive. So that is in the x-axial plane 120 plus 120 plus 150, 180. Then you start reducing minus 150, minus 120, minus 90, minus 60, minus 30, 0. Like that you keep. Every 30 degrees you draw a line. 0 plus 30 plus 60 plus 90 plus 120 plus 150 plus or minus 180. Now you start reducing minus 150, minus 120, minus 90, minus 60, minus 30, and again minus 30 is equal to 0. That is the deadline. So left-sided leads are AVL and L1 are the left-sided leads. Inferior leads are L2, AVF, and L3 are inferior leads. Right-sided lead is AVR. Okay. There are 6 cameras photographing the frontal plane. This is the 6 camera photography. As though you have, what you do, you go to Taj Mahal or any monument. your friend will take one from the front. Another person will take 30 degrees angle. Another person will take 90 degrees angle. Another will go to the back and take 180 degrees angle. So like that, you go on picturing the Taj Mahal in 6 different angles. And ultimately, you see the Taj Mahal. All the pictures together represent the Taj Mahal. Likewise, here heart also is photographed by 6 cameras. So 3 bipolar leads and 3 unipolar leads. In addition to that, we have 6 more cameras which are in the horizontal plane or the transverse plane, which are the chest, 6 cameras on the chest leads or the transverse plane or horizontal plane. This is the frontal plane. Frontal plane, we have put 6 cameras. What are the 3? What are the 6? 3 bipolar leads, L1, L2, L3. 3 unipolar leads, AVR, AVL, AVF. L1, L2, L1 and AVL are the horizontal leads which are facing on the left side as seen in the diagram. We call them as left-sided cameras or left-sided leads. L2, AVF, L3 are the ones which are vertical cameras which are inferior in position to the heart. So that is why they are called inferior leads or inferior camera. AVR is the horizontal lead, which is the right side camera. It's also called the cavitary lead. It faces the cavity of the heart. It is called the cavitary lead. In addition to these 6 leads, limb leads and 6 limb leads, which are the unipolar and bipolar, we also have 6 other leads, which are the V1 to V6, which I have shown you how to position them. They are all positioned in the transverse plane of the heart. So we have lateral leads. When I say lateral, there are 2 lateral leads on the chest, which are V5 and V6 are in the anterior axillary line and in the mid axillary line, which are the lateral leads. So when I say lateral leads, these 2 will come, L1 and L2 and also V5, V6. When I say inferior leads, I don't have any lead on the chest which is facing the inferior part. So I only have these leads, which are the L1 AV, L2 AVF and L3 are the inferior leads. So which are the ones which are on the septum of the heart? V1 and V2 are called the septal leads. V3 and V4 are called the anterior part of the heart, anterior leads. Anterior lateral, when I say V3, V4, V5, V6, L1, AVL. So if the changes are seen in the lateral leads, it is called lateral wall infarction. If you have infarction changes in the lateral leads, we call it as lateral myocardial infarction. What are the lateral leads? L1, AVL, V5 and V6. These are the cameras placed on the left lateral side of the heart. Inferior leads are the 3 cameras, L2, AVF and L3. If any changes are depicted here and the myocardial infarction is seen in L2, AVF and L3, we call it inferior infarction. If the changes are seen in V1 and V2 on the chest, it is called septal leads, septal infarction. V3 and V4 is called anterior leads. Anterior septal means V1, V2, V3, V4. Anterior lateral means V3, V4, anterior, lateral part V5, V6, L1, AVL is anterior lateral. So usually the infarctions are recorded as lateral infarction, inferior infarction, septal infarction, anterior infarction, anterior lateral infarction, and a combinations, anterior inferior and inferior lateral, like that. You can have various combinations of the infarction. So remember this 12 camera concept. 6 cameras are in the frontal plane, 6 cameras are in the transverse plane on the chest. Frontal plane leads are 3 of them are unipolar leads, AVR, AVL, AVF. 3 of them are bipolar leads, L1, L2, L3. So left-sided cameras are L1 and AVL are the left-sided cameras. L2, AVF and L3 are the inferior cameras. AVR is the cavitary lead on the right-sided camera. There is only one camera on the right side because the electrical activity of the heart is flowing from above down towards the left and posteriorly. What is the direction of electrical current? Electrical current from above to down and from right to left, from anterior to posterior. This is how the cardiac activity occurs. The electrical current travels from above to down, from your second space to the fifth space on the left side, second space on the right side to the fifth space on the left side, and towards the left, from right to the left, and also from anterior to posterior. That is why we have not placed many cameras on the right side, because our activity is mostly towards the left and down, left and down, inferior and lateral. The main current goes inferior and lateral. So we have kept lateral cameras, L1, AVL, V5, V6, and inferior cameras, L2, AVF, and L3. And we wanted to know something on the front of the heart, that we are recording by the transverse plane leads. V1, V2 are the septal leads, V3, V4 are the anterior leads, and anterior septal means V1, V2, V3, V4. Anterior lateral means V3, V4 coupled with the lateral leads, which are V5, V6, and L1, AVL. This part you must very clearly keep in your mind. So I am showing the transverse plane. These are the septal leads, V1, V2. V3, V4 are the anterior leads. V5, V6 are the lateral leads. This is on the left side. Right side, we don't keep any leads because the cardiac activity, if you take the heart like that, the impulse is down from right to left and also anterior to posterior. Inferior and left and posterior. That is the direction of the cardiac current. That's why it is like that. So 6 cameras are photographing anterior posterior plane of the transverse plane. V1, V2 are the septal leads. V3, V4 are the anterior wall. V5, V6 are the left lateral lead. Record right-sided event. Suppose in a case of dextrocardia or right ventricular infarction, you have to keep the leads on the right side. Then we call them as V2R, V3R, V4R. I have already told you about that. So what are the leads I need to look at for axis? L1 and AVF. Mainly L1 and AVF I look at. This will tell me one is a left camera, the other is an inferior camera. L1 and AVF. So recording the axis of lead 1 is like this towards the left, and this is the vertical axis is the foot. This is the AVF. So electrical impulse starts from the atria, conducts. This is the AV bundle, then activates the ventricle, and the QRS, isoelectric line, and the T wave. So that's how it occurs. This is the electrical activation. Electrical activation is from the sinoatrial node through the atrial activation to the AV node bundle of his, and then the bundle branches, left bundle branch, right bundle branch, Purkinje system, and activation. Okay. Now, what is left axis? What is right axis? What is normal axis? If you understand. If a cardiac axis is anywhere here, green color, it is called the normal axis. The cardiac axis is anywhere there, is called left axis. If it is anywhere here, it is called right axis. And this is called indeterminate axis. Usually we will not get ECGs with indeterminate axis. We will get either a normal axis, left axis, or right axis. So how to quickly say whether the ECG is left axis or right axis or normal axis? So that southeastern quadrant is the normal axis, southwestern is the right axis, and the northeastern is the left axis. Northwestern is the indeterminate axis. This is the hexaaxial system. Okay, normal axis when it is downward and to the left. You can see downward and to the left. That is why it is normal axis. And upward and to the left is the left axis. Downward and to the right is the right axis. Upward and to the right is the indeterminate axis. That's what we have understood. Now, what are the leads I should look at? L1, L2, L3, AVF I have given. Either you take L3 or AVF. Both of them are inferior leads. So usually all the complexes are positive deflections in all the 4 leads. Normally, L1 is a positive deflection, L2 is also positive, L3 is positive, AVF is positive. That means if these four leads you look at L1, L2, AVF, and L3, L1 is for the left side, L2 is L3, AVF for the inferior part. If you look at the four leads, if all of them are positive, it is called normal axis, all upright. All the deflections are upright, it is called normal axis. The other way around, L1 is mainly a negative deflection and L3 is a positive deflection. Then there is meeting. This wave is trying to meet the other wave, right? Meet. That means in the right axis, the L1 and L3, they try to meet each other, right? Meet. And then that is they meet each other. That is where right axis is. The L1 wave tries to meet the L3 wave. L1 will be negative, L3 will be positive. In the left axis, L1 goes this way, L3 goes this way, left leave. That means if the L1 is upward and L3 is downward, the waves are leaving each other. That is left axis, which is called left leave. So right meet, left leave. All upright, normal axis. L1 and L3 are meeting each other, right axis. Right meet, left leave. Okay. Normal axis, right axis, and left axis. Normal axis, L1, L2, L3, AVF, all are positive, upstrokes, whereas in right axis, L1 is negative, L3 is up, then positive, and they're trying to meet each other. Right meet, left leave. In the left axis, L1 is going up and L3 is going down. The waves are leaving each other. We call it as left leave. Okay. Now, see here, normal axis, L1 is positive, AVF is positive, tip is both are upright. Right axis, L1 is negative, AVF is positive, the waves are meeting, right meet. Left axis, L1 is upstroke, AVF is downstroke, they are leaving each other, left leave. Indeterminate axis, we are not considering here, in which case L1 will be negative, AVF is positive. So we are not interested in that. We will say right axis, right meet, left axis, left leave. Now in this ECG, what is the axis? So L1, L2, L3, AVF, all four are available. Now I'm not able to hear you clearly. I just listen to what is that and put the question in the chat box if you have. Okay, L1, lead 1 up, lead 2 up, and AVF up, and L1, L2 we have to see, and L3 also, all are positive deflections. That means it is a normal axis. When all are positive, it is a normal axis. Now, you see here. Now, here look here, L1 is down, L2, L3 is L3 or AVF is up. So we consider L1 and AVF. Who is speaking? Okay. So in this ECG, lead 1 is down and lead 3 or lead AVF or L3 is up. So these are trying to meet each other. Right meet is right axis. Okay, this is right axis. Then note QRS voltages are positive and upright in leads 2 and AVF and negative in L1. That means they are trying to meet right meet criterion. QRS L1 and AVF meet right axis deviation. And here you see the QRS is up this side and the QRS down. They are leaving each other. L1 and L2 are leaving. L3 are leaving each other. Either you use L3 or AVF when these are leaving each other, and naturally it is a left axis. Now I'll give you an ECG. You have to identify. If you give an ECG, you can take any ECG and start identify by applying the criteria. If all four are positive, L1, L2, L3, AVF, all are positive deflection, it is a normal axis. If L1 is negative, and L3 or AVF is positive, the waves try to meet each other. It is called right axis. Whereas when L1 is positive, L3 or AVF is down, the waves are leaving each other. That is left axis. Right meet, left leave. So this is today what we did. We did about the paper. We did about the intervals, various intervals. We also understood the various waves on the ECGs. Then we looked at the rate 300, 150, 100, 75, 60, like that, and also looked at the axis deviation, right axis deviation and left axis deviation. So atrial hypertrophy, ventricular hypertrophy, we will consider in the next class. I will discuss with the PGs and then announce the next class when all of you can be present. So somebody has put left axis, right axis, like that. It is good that you are able to put some messages. Remember, all the 4 leads are positive, L1, L2, L3, AVF, positive deflection. You don't have to worry, it is a normal axis. Normal axis is to the down and left. That is the green quadrant there. Whereas if something is up and left, which is left axis, then the waves leave, L1 and AVF will be leaving each other. The other way around, L1 is down and AVF is up, they're trying to meet each other. It is the right and left quadrant, right and down quadrant. That is called the right axis. Indeterminate axis, I am not telling you now. When we get such ECG, I will show you about that. So now you have got tips to, you now understand what are the, I'm summarizing today. P wave is 0.12 seconds. PR interval is 0.2 seconds. Okay. And then QRS complex is 0.08 seconds. QT interval is half of RR interval, which is 0.4 seconds. T wave is 0.2 seconds. And TP segment is also 0.2 seconds. And then PR interval is 0.2, I have already told. RR interval is 0.8 seconds. Half of the RR interval is the QT interval. So you have to know the duration of the waves, and the x-axis is the time, and y-axis is the amplitude. And depending on that, how many millimeters the wave is there, you calculate on the y-axis. How much time it took, you calculate on the x-axis. And the rate determination, first line after the initial QRS complex, bold line is 300, next is 150, 100, 75, 60, 50, 43, and 37 are the numbers you give. And depending on that, you can tell the rate, whether it is normal heart rate or tachycardia or bradycardia. Then you have the axis for which we have got the frontal cameras and the transverse cameras. Frontal cameras, L1 and AVF, L1 and AVL are the left-sided cameras. L2, L3 and AVF are the inferior cameras. AVR is the cavitatory lead as the right-sided camera. In the transverse axis, V1 and V2 are septal leads, V3, V4 are anterior leads, V5, V6 are lateral leads. Anteroseptal, V1, V2, V3, V4. Anterolateral, V3, V4, V5, V6. So when you say lateral, automatically L1 and AVL also will come. When you say inferior, L2, L3, AVF will be the cameras that will be recorded. Depending on that, you can say inferior infarction, lateral infarction, anterior infarction, septal infarction, anterolateral infarction, anteroseptal infarction, like that. Now, when you come to the axis, you have to look at L1, L2, L3, and AVF. All 4 are positive, then it is normal axis. Then you examine carefully if L1 and L1 and AVF or L3, one of them, they are meeting each other, it is right axis. If L1 is downstroke and AVF or L3 is an upstroke, they are meeting each other, it is right axis. Then if L1 is upstroke, L3 or AVF is a downstroke, they are leaving each other, it is left axis. So simply you can say left axis or right axis. Now what you do is go back to your wards, look at the ECGs, find out the rate, find out the axis. Up to the point we have learned, you apply your knowledge and see. And write the intervals of P wave, QRS, QT in that particular ECG. You say, first of all, you identify the ECG, identify the waves, P wave, QRS, T wave, ST segment, PR segment, and all that, and identify the intervals, and write the duration of each of the waves. P wave duration, this much, PR interval, this much, QRS duration, this much, and then QT interval is this much, T wave duration is this much, RR interval is this. Write that first report. Second one is, what is the rate? Apply the 300-150 rule and find out the rate. And if it is between 70 and 60, 75 and 60, you see to which it is nearer and decide. Between 75 and 100, you see to which it is nearer and then approximately tell the rate. Then you also look at the L1, L2, L3, AVF and then find out the axis. All four are up. Normal axis. L1 down, L3 or AVF up is called right mid, right axis. L1 up, L3 or AVF down, that means it's a negative deflection. It is there leaving each the left axis. So you please do this exercise, then you will know exactly how to interpret the ECG up to this point. The next point is atrial hypertrophy, ventricular hypertrophy. I will take both of them in one class, atrial hypertrophy and ventricular hypertrophy.